All right, welcome in everyone to another deep dive. Today we're taking a look at mixed aortic valve disease. I think this is going to be a really fascinating one,
Absolutely.
and I am really happy to have you here to walk us through this one.
Always a pleasure.
So just to orient everybody real quick, we're
Yeah.
talking about the aortic valve. Uh, that's that all-important, doorway out of the heart, the one that lets the blood go to the rest of the body. And what we're looking at is what happens when you have both a narrowing, what's called stenosis,
Yeah.
and also a leakiness, which is
Sure.
called regurgitation. And that's what mixed aortic valve disease is. You have both at the same time.
Exactly. A double whammy.
Right. And that's what makes it so interesting. So you shared some really good medical info about how this condition is diagnosed and treated. And what we're going to do in this deep dive is really unpack it and try to figure out what's so important about mixed aortic valve disease.
Yeah, why understanding the nuances of this condition really matters.
Absolutely. So let's jump right in. One of the things that was really interesting in the materials is how doctors actually make this diagnosis.
Yeah.
And it starts with the physical exams,
Yeah.
right?
Yeah, that's where it all begins.
Right. And so, they talk about a case where, the patient's heart is beating regularly
Mm-hmm.
in what we call sinus rhythm.
Right.
And there aren't any obvious signs,
Nothing
externally,
jumping out at you.
of a heart problem. But
Yeah.
when you feel their pulse, it has this slow rising character to it.
Ah, interesting.
Right. And then when you actually feel the chest and feel the apex beat, that's where the heart is beating strongest. Feels really strong, like it's heaving,
Yeah.
but it's not actually shifted out of place.
Right. So it's not displaced.
Right. So I thought that was really interesting.
Yeah, those are really important clues.
Yeah. And so what does that actually tell us? Like, what do those clues tell us?
Well, let's take that slow rising pulse, for example. That can be a classic sign of aortic stenosis, so think of it like this. Imagine you're trying to push a lot of water through a really narrow straw.
Okay.
It's going to take longer to build up that pressure and for the full volume of water to actually come out, right?
Yeah.
It's the same thing with the heart. If that aortic valve is narrowed, it's going to take longer for the heart to push all the blood out, and that's why you get that slower rise in the pulse.
Oh, that makes sense.
And then that heaving, non-displaced apex beat that often tells us that the heart muscle, specifically the left ventricle, has actually gotten thicker,
Right.
which we call left ventricular hypertrophy.
Oh, wow.
And that happens because the heart's working harder, right? It's got to push against that narrowed valve. And just like any muscle, when it works harder, it gets bigger.
Right. So it's like it's building up, bulking up.
Exactly. It's bulking up to try and compensate.
Okay. So that's what we can learn just from feeling. But then, of course, there's listening to the heart.
Of course, auscultation.
Right, auscultation with the stethoscope. And there they heard a couple of things. They heard what's called an ejection systolic murmur, which is a sound you hear when the blood's being forced out of the heart. And that was loudest at the left sternal edge and the aortic region.
Right, so right over where the aortic valve is.
Exactly. And it was also radiating up to the carotid arteries in the neck. And then they also heard an early diastolic murmur in the same areas.
Ah, okay, so two distinct murmurs.
Right. So what do those tell us?
Well, that ejection systolic murmur that's radiating to the carotids, that's a really strong indicator of aortic stenosis.
Okay.
It's literally the sound of the blood struggling to get through that narrowed valve.
Okay.
And then that early diastolic murmur. That's a hallmark of aortic regurgitation. That's the sound of the blood leaking back into the left ventricle when the aortic valve should be closed tight.
Right. It's not holding it in.
Exactly. It's not holding it in.
So both those murmurs together are really what point to this mixed aortic valve disease.
Absolutely. It's that combination that raises the suspicion.
Now, if you have both of these murmurs present, how do you figure out which one is, I guess, the dominant problem? Like, which one is having the bigger impact?
Yeah, that's a great question because in mixed disease, it's not always equal, right?
Right.
One might be more severe than the other, and in this case, they actually say that aortic stenosis was considered to be the main issue.
Okay.
And the reason for that is really interesting. They looked at the character of that systolic murmur, how it sounded, along with that slow rising pulse we talked about,
Yeah.
the fact that it was radiating to the carotids and that the apex beat wasn't displaced.
Right.
All those things pointed more towards stenosis being the primary problem.
Okay, that makes sense.
It's like putting together the pieces of a puzzle
Yeah.
to see which one's really driving the clinical picture.
Now, the source material also mentions something called the Austin Flint murmur.
Ah, yes, the Austin Flint murmur.
Did you tell me where that's heard and what causes it?
So you'd hear this murmur best at the lower left sternal edge, which is actually where you typically listen for mitral valve problems. And what's fascinating about this murmur is it's not actually directly caused by the aortic valve itself. It's a consequence of that regurgitant jet, that blood leaking backwards through the aortic valve.
Oh,
That jet hits the anterior mitral valve leaflet, the front flap of the mitral valve, and it can actually make it vibrate.
oh, wow.
And that vibration is what creates the Austin Flint murmur.
Wow. So it's like an echo almost, an internal echo?
Exactly. It's like an internal echo, that backward flow causing another valve to vibrate. It's really interesting.
It's like a domino effect almost.
Yes, yeah, you could say that.
Wow. So we have all these findings from the physical exam pointing to this mixed aortic valve disease. What are the next steps? What kind of tests do they need to do to confirm the diagnosis?
So the first thing is a really thorough patient history, really focusing on any symptoms they might be experiencing, things like chest pain, shortness of breath, dizziness, any of those things. Then you want a full set of blood tests, to check their overall health. And importantly, blood cultures, if there's any suspicion of infective endocarditis,
Right.
which is an infection of the heart valves, that can actually cause or worsen these valve problems.
So we got to rule that out.
Absolutely.
And then I guess an ECG.
Yeah, an electrocardiogram or ECG is really important to see the heart's electrical activity, check for any rhythm problems or signs of that heart muscle thickening we talked about,
Makes sense.
and then a chest x-ray. That can tell us if there's any fluid in the lungs, which could mean heart failure, and it can also give us a look at the aorta itself to see its shape and size.
Okay, so that's a lot of information from those tests, but there's one that the sources really highlight as the most important.
Yeah, the gold standard, the transthoracic echocardiogram, or echo for short.
The echo. Okay, so remind us again why that's so critical.
Well, the echo is an ultrasound of the heart,
Oh.
and it gives us this amazing detailed view of the aortic valve. We can actually see how narrowed it is, how much blood is leaking back, and we also get crucial information about the left ventricle, how well it's squeezing, how thick the walls are. We can even measure something called the ejection fraction,
Okay.
which tells us what percentage of blood the ventricle pumps out with each beat.
And what's a normal ejection fraction?
A normal ejection fraction is usually above 55%. So if it's lower than that, it suggests the heart's not pumping as well as it should.
Okay, so we're looking at the valve itself and then also how the heart is functioning overall.
Exactly. It's a comprehensive assessment.
All right, that makes a lot of sense. So we've talked about how it's diagnosed, investigated.
Yeah.
Let's talk about how it's actually treated.
Sure.
So what are the different treatment strategies for mixed aortic valve disease?
Well, it really depends on whether the patient is having symptoms or not.
Okay.
If they're not having any noticeable problems, they're feeling fine.
Yeah.
The approach is usually medical management, and that means carefully managing any other heart conditions they might have, like high blood pressure, coronary artery disease, things like that. They might use beta blockers to manage symptoms if they do start to appear.
Okay.
ACE inhibitors or ARBs if the left ventricle is affected, and diuretics to help with any fluid retention. But it's important to remember, this is about managing, not fixing the valve issue.
Right, so it's kind of like keeping things under control while you wait and see.
Exactly. It's a watchful waiting approach.
Okay, but if the patient is having symptoms...
Then the strategy changes. For symptomatic patients, the goal, when appropriate, is to replace the faulty valve.
Okay.
And there are two main ways to do that. Percutaneous aortic valve implantation, which we call TAVI.
KVI. Okay.
And then the more traditional surgical valve replacement.
Right, open heart surgery.
Exactly.
So TAVI, that's the less invasive one.
Yes, it's less invasive. They use a catheter to insert a new valve through an artery, usually in the leg, whereas surgical replacement is a bigger operation. They open the chest and replace the valve directly.
Okay. And the choice between those two depends on a lot of factors.
Absolutely. The patient's age, other health problems, the specifics of their valve problem, all those things factor into the decision.
Okay, so let's get into the nitty-gritty.
Let's do it.
The real key characteristics of this mixed disease. What makes it so unique is this combination of the narrowing and the leaking. So can you walk me through a little more about what's actually happening with the valve, how it can cause both of those problems?
Sure. So what's fascinating is that a single stiffening valve can lead to both stenosis and regurgitation.
Okay.
As the aortic valve gets calcified and less flexible, which is what happens in stenosis. It not only narrows the opening, making it harder for blood to get out, but it also often doesn't close completely. So you get that backflow, that regurgitation. So it's like a door that's both hard to open and doesn't latch shut properly.
Right, so it's not working right in either direction. So what are the different things that can cause both of these problems?
Well, there are chronic causes, things that happen over time, and then acute causes, things that come on more suddenly.
Okay, so let's start with chronic aortic stenosis.
All right, so for stenosis, the most common reason is simply age-related calcification.
Okay, so just wear and tear.
Exactly, the valve just wears out over time. Another common cause is a bicuspid aortic valve,
Okay.
which means the valve only has 2 leaflets instead of 3, and those valves tend to wear out faster.
Okay, so you're starting out with a different valve.
Yeah, it's a congenital thing, and it makes them more prone to problems.
Makes sense. And then any other chronic causes of stenosis?
Yeah, you've got rheumatic heart disease,
Okay.
which can damage the valves after a strep infection, and some less common things like Fabry's disease, lupus, Paget's disease.
Okay, so a whole range of possibilities.
Yeah, it's a pretty diverse list.
And what about chronic aortic regurgitation, the leaky valve? What are the causes there?
So regurgitation can happen because of problems with the valve leaflets themselves, or with the aorta right above the valve, what we call the aortic root.
Okay.
Rheumatic heart disease is still a big cause globally.
Okay.
But in developed countries, we see it more often with things like connective tissue disorders, Marfan syndrome, Ehlers-Danlos syndrome, and then long-standing high blood pressure, some bone disorders, a condition called myxomatous disease, where the valve tissue gets weak, and inflammatory conditions like ankylosing spondylitis, giant cell arteritis, and lupus again.
Wow. So it can really be a lot of things.
It can. It really highlights how interconnected everything is.
Right. And then what about those acute causes, the ones that come on suddenly?
So acute aortic regurgitation often happens because of things like infective endocarditis, which is that serious valve infection we talked about,
Okay.
or trauma to the chest,
Well,
or an aortic dissection, which is a tear in the aorta itself.
wow, those are serious.
Yeah, those are definitely situations that need immediate attention.
Now, the sources mention some really interesting findings that are specific to aortic regurgitation, like this thing called a collapsing pulse.
Ah, yes, the collapsing pulse, very descriptive name.
What is that and what causes it?
So it's also called a water hammer pulse
Okay.
because it feels really rapid and forceful, and then it quickly disappears.
Wow, that's interesting.
And it happens because of the wide pulse pressure we see in aortic regurgitation.
Okay. Remind me what pulse pressure is again.
Pulse pressure is the difference between your systolic and diastolic blood pressure.
Okay.
And in aortic regurgitation, because some blood leaks back into the ventricle, your systolic pressure tends to be high and your diastolic pressure drops low.
Okay, so a big gap between the two.
Exactly, a big gap. And that creates that collapsing pulse.
Wow, that's fascinating.
And there are other cool signs associated with this wide pulse pressure.
Really?
Yeah, like the Massey sign, which is bobbing of the head with each heartbeat.
Oh, wow.
Quit de sign, a visible pulsation in the nail beds or lips. And Muller sign, a pulsation of the uvula, that little thing that hangs down the back of your throat.
Wow. That is a lot of interesting things you can see just from looking.
I know, it's amazing what the body reveals.
Right. And so you mentioned that slow rising pulse in aortic stenosis. How does that compare to this collapsing pulse in regurgitation?
Well, the slow rising pulse is much more gradual. It takes time to feel that peak strength, reflecting that extra effort the heart needs to push the blood through.
Right. It's working harder.
Exactly. Whereas the collapsing pulse is very sudden, then it disappears quickly.
Okay, so they feel very different.
Oh, yeah, very distinct.
And with both of these, it's important to check if the pulse is regular, right?
Absolutely, because irregular heart rhythms can happen with valve problems.
Okay, good to know. The sources also mention something called Gallivardian's phenomena.
Gallivardian's phenomenon, yes.
What is that?
So this is when the murmur of aortic stenosis, which is usually heard best at the base of the heart and radiates to the neck, can also be heard clearly at the apex of the heart, which is where you usually listen for mitral valve murmurs.
Okay, so it's kind of like it's traveling.
Yeah, it's like the sound is being conducted differently.
Interesting.
We don't know exactly why it happens, but it's a cool finding.
Okay, and just to be clear, if you only had aortic stenosis versus only aortic regurgitation, what would you hear differently on auscultation?
Okay, so with pure aortic stenosis, you'd hear that harsh ejection systolic murmur, loudest at the base of the heart, radiating to the carotids. The second heart sound might be quieter or even absent
Okay.
with pure aortic regurgitation. You'd hear that early diastolic murmur best heard along the left sternal border. and it often gets louder when the patient leans forward and holds their breath.
Interesting. Now, you can sometimes hear an ejection systolic murmur,
Yeah,
even in people who have aortic regurgitation.
you can, yeah.
So how do you tell that apart from the murmur of stenosis?
So that murmur and regurgitation, it's not because of a narrowed valve. It's because of the increased volume of blood the left ventricle has to pump because of the backflow.
Oh, right, it's overfilled.
Exactly, it's overfilled, so it has to work harder. So you hear a murmur, but it usually doesn't radiate to the carotids.
Okay, so that's the key difference.
That's the key difference, yeah.
And one last thing about the physical exam.
Yeah.
What do you feel when you palpate the apex beat in stenosis versus regurgitation?
Okay, so in stenosis, the apex beat is usually in the normal spot, but it feels really strong and sustained because of that thickened left ventricle.
Right, it's working overtime.
Exactly. In regurgitation, the apex beat is often shifted to the side,
Ah.
and it feels more diffuse or tapping because the ventricle is enlarged and filled with more blood.
Wow, so really different findings there.
Yeah, you can learn a lot just from feeling.
So the physical exam gives you a lot of info, but those other tests are still really important.
Oh, absolutely, especially the echo.
Right, so can you just remind us again why the echo is so crucial?
So the echo lets us directly see the aortic valve. We can see the thickening, the calcification, any leaking. We can assess the left ventricle, its size, its function. And in regurgitation, we also look at the aortic root for any widening.
Okay, so it really gives you a comprehensive picture.
Exactly. It's our window into the heart.
And what about the ECG and the chest x-ray? What are we looking for there?
Well, the ECG can show signs of left ventricular hypertrophy, that thickening of the heart muscle. It can also pick up on any atrial arrhythmias, which are irregular heart rhythms.
Okay.
And the chest x-ray can show pulmonary edema, fluid in the lungs, which is a sign of heart failure.
Right.
And it can also show enlargement of the aorta or calcification around the valve.
Okay, so we're looking for any signs of problems or complications.
Yeah, any clues that tell us how severe the situation is?
Now, the sources also mention exercise testing, especially for aortic stenosis. When would a doctor order that test, and what does it tell us?
So exercise testing is really helpful in a couple of situations. First, it can unmask symptoms in patients who say they feel fine,
Okay.
but actually have severe stenosis. So when they exercise, their heart has to work harder. And it can reveal limitations or symptoms they weren't having at rest.
Oh, so it's kind of like a stress test.
Yeah, you could say that. And it's also really important for evaluating low-flow aortic stenosis.
What's low-flow aortic stenosis?
So sometimes, if the left ventricle is weak, the pressure difference across the valve might not be that high, even if the valve is very narrow.
Okay.
So we do a stress echocardiogram, where we either have them exercise or give them a medication to make their heart beat faster. And that helps us distinguish true severe stenosis from pseudostenosis. If it's true stenosis, the valve area won't increase much even when the heart's pumping harder. But if it's pseudostenosis, it will.
Okay, so it's like you're really challenging the heart.
Exactly. We're seeing how it responds under pressure.
Makes sense. And the sources also mentioned cardiac CT.
Yeah, cardiac CT is becoming really useful, especially for assessing calcium buildup on the valve. And that can help us estimate how severe the stenosis is.
Okay.
So it can be an alternative to exercise testing in some cases.
All right, so we've covered diagnosis, investigation. Let's go back to treatment for a minute.
Sure.
You mentioned that surgery is the definitive treatment.
Yeah, if you want to fix the valve itself, surgery is the way to go.
Right. And medical management is more about support.
Exactly. It's about controlling symptoms and managing other conditions.
Okay, so can you talk a little more about those surgical options?
So the two main options are surgical valve replacement and transcatheter aortic valve implantation, or TAVI.
TAVI, right.
So in surgical replacement, they open the chest, remove the old valve, and sew in a new one. The new valve can be mechanical, which is very durable, but you need blood thinners for life.
Okay.
Or it can be biological, which doesn't usually need blood thinners, but it might wear out over time, especially in younger patients.
Right, so there are trade-offs with each type.
Yeah, there are pros and cons to consider. And then TAVI is less invasive. They insert a new valve through a catheter, usually in the groin,
Right.
and it's expanded once it's in place.
Okay, and TAVI is mostly used for stenosis.
Yeah, it's become the primary treatment for severe stenosis, but it's less common for pure aortic regurgitation.
Why is that?
Because in regurgitation, the aortic root is often dilated, and that can make it hard to get a good fit for the TAVI valve.
Okay, so it's not as effective.
Not as effective, and it can be more risky.
Now, the sources also mentioned valvuloplasty.
Valvuloplasty,
What is
yes.
that, and when is it used?
So valvuloplasty is where they insert a balloon into the aortic valve and inflate it to try and stretch it open.
Okay.
It can provide some relief, but it's often temporary. And the valve can narrow again, which we call restenosis.
So it's not a permanent fix.
No, not really. So it's usually reserved for patients who are very sick, like those in cardiogenic shock or unstable angina.
Yeah.
Stabilize them until they can have surgery.
Okay, so it's like a bridge to something more definitive.
Exactly, a bridge to surgery.
And finally, the sources gave some guidelines for when surgery might be recommended, even in patients who aren't having symptoms.
Yeah, that's an important point. Even if you feel fine, if your ejection fraction drops below 50%, or if the left ventricle gets too big, they might recommend surgery. Because it means the valve problem is starting to affect the heart's function.
Okay, so it's like preventing further damage.
Exactly. It's about being proactive.
Okay, this has been a really amazing deep dive. So just to sum up for our listeners, mixed aortic valve disease is a complex condition.
It is, yeah.
It's not just one problem. It's this intricate interplay of both a narrowing and a leak. And diagnosing it requires careful attention to those physical exam findings,
Yeah.
especially the murmurs and the pulse. And then confirming it with those advanced imaging techniques like the echocardiogram. And then treatment, it really varies. Ranges from medical management for folks without symptoms to those more definitive surgical or percutaneous valve replacements for people who are having symptoms or those who are showing concerning changes in their heart function.
You've got it.
And I think what's so amazing about this is how these two opposing forces, the obstruction to flow and the backward leakage, can both happen in the same valve.
Yeah, it really is remarkable. It highlights how delicate the balance is in the cardiovascular system.
Absolutely. And so that leads me to a final thought for everyone listening. Given how complex this condition is and how it demonstrates the fine balance within our cardiovascular system, what does that tell us about the overall resilience of our hearts, but also the potential for things to go wrong?
Yeah, it's a good question to ponder.
Right. And what does it mean for each of us to be proactive about our heart health and to stay aware of any potential issues? That's something to think about.
Absolutely.
Thank you so much for joining us for this deep dive.
My pleasure.
We'll see you next time.